We're going to try and do it interactive, and because we had so many topics, and now you're all not only the roundtable people who came as experts, now I hope you all are experts, and we're going to have some polls discussion, so please take out your phones. I know everybody has an iPhone or an Android, so there's no excuse. And I'm going to give you some statements on craniosynostosis, and then we'll have a poll from the audience, and then we'll have a discussion with the panel, and probably we won't have a consensus, but we will try. And in the end, we will also have one case which I think is just very similar to the cases we saw now in the last session, just to discuss things again and go over these things. Okay, ready? You can see it here, the QR code, or you go to slido.com and give in hashtag synostosis. I love these polls. It's so interesting. Do I need to give you the instructions, Andrea? You need to scan the QR code and answer the questions. Okay, so the first question, the first statement is, imaging, CT or MRI should be done to verify the diagnosis of craniosynostosis. Okay, 81%, 82%. Disagree? Okay, 80-20. Are you done? Okay, let's say 80-20. May I ask the panel, you will have to tell us what you voted, so we know what you think. So what do you think? Is imaging needed for the diagnosis of craniosynostosis?
I have to agree and disagree, because
Okay.
because for obviously CT scan is outdated now for the diagnosis, but MRI is a real question, because we, for instance, in my center, they do MRIs without general anesthesia to children before 1 year of age, and the single suture craniosynostosis, as Irene Matthijssen underlined, may be primitive brain disorders. So we need to go further in the understanding of the brain anatomy in those patients. So maybe we still don't have the tools to analyze properly their MRIs, but I think that there'll be a point where we will need proper and detailed brain imaging for single sutures craniosynostosis, and especially for trigonocephaly. So it may not be such an easy question.
Can I maybe ask you, do you know how many, from the MRIs that you do, maybe the neurosurgeons have to answer that, how many MRIs show brain anomalies?
None. But
you can pass the microphone. No, I'm kidding.
But we have been assessing them with dedicated tools that are not part of the standard clinical use now, and they show anomalies, as Irene showed you in one of her papers, and we're also working on the topic. So to prepare the maybe in the future, MRI will be part of the standard clinical screening of single sutures.
I understand what you're saying. Okay, I think it's a interesting point.
Okay, I agree with him, but of course, for the diagnosis of single suture, especially sagittal suture, the ultrasound is just enough. If we have any doubt about something different, something additional, yes, often we always
then you
do.
would. If you have a doubt of syndromatic or something more, then you do. If you have a kid which is normal looking, normal phenotype, let's say normal development as far as you can say for a 2 months old, but with the bicoronal synostosis, not a single suture, but everything other is normal. Would you go for an MRI, or would you just?
Bicoronal, yes.
You would?
Yeah, because of the high incidence of genetic malformation in bicoronal.
Do you agree, Radek?
Personally, I agree. I mean, sticking to the text of the question,
yeah,
the answer is disagree. So, with all these nuances.
Yeah. So you, for single suture synostosis, you wouldn't do an MRI.
No.
But I understood correctly, you would do it for the purpose of research, more thinking about the future, and maybe we would need it for research.
But in practice, we perform the MRI.
You do it. Yeah.
Because we can do it without general anesthesia.
Yeah.
That's the main reason.
but it costs.
Well, sometimes the problem is solved by referral colleagues. They send us the patient already with MRI.
Yeah, if you get a referral with MRI, you're lucky. We get referrals with the skull X-ray,
Yeah,
which is useless, as you know. Okay, please, no skull X-rays in craniosynostosis. Please don't do it. I think here we can all agree, right? Okay. You do skull X-rays?
Skull X-rays we do for follow-up of 5 years of age to check for bone defects.
Okay.
We still do it. We do front lateral skull X-rays.
Really? But bone defects, you palpate them.
Yeah, we palpate. That's part of our.
Okay.
But sometimes they're in video consultation.
You mean if you don't see the patient? Yeah. Okay. But I think if you have skull defects, usually you palpate them, and if they're small, then probably there's no consequence. But if you do it for research to know how many of them have bone defect, I can understand. But I think in clinical practice, probably not needed, but no, interesting to hear.
I mean, it's the remain of our old.
Okay. What do you think, Benito?
I also clicked the disagree, but somehow I also agree. So I was missing the it depends button. So I was discussing in between during the break with the radiologist, and maybe in a coronary unilateral coronary suture craniosynostosis, it might also depend whether it's really just the coronary suture or it's the coronary ring which is completely fused, which makes it different from the approach. We might need to open the sphenofrontal suture also, or in the orbit. So it goes into direction of the presentation of Irene also, why maybe distraction then might be a better option. So if we really can, from the phenotype, exclude that it's not the case, and also with sonography, then not, but otherwise, maybe in some cases.
But you don't think you would make it more dependent on what you find clinically? Because I think, if the suture is closed all the way down, and also the other sutures might be closed as well, you would see something different, no? Or you think we wouldn't detect that clinically?
I'm not sure whether we look thorough enough in that area clinically, and also with sonography.
So maybe we should.
Maybe we should.
Shlomi, what do you think?
No, I agree that outside of a research protocol, which is a different thing, I wouldn't do any imaging, not even ultrasound. I think also our craving to know about subtle things in the brain that have no clinical significance is overrated, and this may cause a lot of anxiety to the parents. So I don't want to know if there are little problems in the parenchyma, let's say, that have no clinical significance at a certain point. I don't want to know about them. And about imaging affecting the type of surgery for single suture synostosis, I don't think it changes the type of surgery. If you have a question on board, a borderline case, of course, this is different. For bicoronal, I do imaging. I treat bicoronal as if it is a syndromatic craniosynostosis.
Okay. Yeah, just one point about the MRIs. Remember, we had 3 or 4 years ago a topic about incidentalomas, which is something that we're also looking at in the ENS and ISPN, and there's something we call VOMIT, victims of modern imaging techniques. Keep that in mind. We find lesions, and we have our tumor board is swamped with lesions that we follow for years in these kids. And the more MRIs we do, the more low-grade gliomas, hamartomas we find, which stress out the patients, stress us out, and give us more work, which is okay, but we need to think also about that sometimes it costs money, of course, but sometimes we find things that, like you say, Shlomi, we don't want to know about them.
True, but we are dealing with populations with a significant number of cognitive cognitive disorders that we don't understand. So we don't know why there is a fixed number of patients with trigonocephaly who have cognitive abnormalities, and it may have some anatomical correspondences that we haven't understood yet. So we owe this to the families to have some predictive factors.
The question is do we want to just do it, or do we want to do it in a protocol? It's a little bit like biopsy. I'm taking now to the neurosurgical, biopsying DIPG. Do we want to just biopsy DIPGs, or do you want to do it within a protocol where we will look at the tumor markers, etc.? I think it goes in a direction, you know, if I agree with you, it's a different population, but sometimes we need to think, we need to do it within a protocol and ask ourselves, what are we looking for, etc., etc. But in principle, I personally would agree that for the diagnosis itself of single suture craniosynostosis, it's a clinical diagnosis. Yeah, and also CTs, usually we try not to do it. MRI, we can discuss. Would that be a good consensus? Any comments from the floor? Yeah?
Not really a comment, but more a question to a comment. Will someone here has an experience or would do an imaging more for parent reassurance than for another reason? Example, we have a kid referral with a head which is not really symmetrical, but not really clinically craniosynostosis typical, and then the parent is really worried and my kid is not normal. Would you send him for an imaging to maybe yourself because you're in doubt, or to reassure the parents?
An ultrasound.
Yes, you have ultrasound, but sometimes not enough, and you want to be sure with some other imaging, no?
And there, photogrammetry could be a nice tool because you can. This photogrammetry could be a nice tool because you can take a picture, you can reassure them and explain them why this head shape does not correspond to any craniosynostosis shape, you know, and then you can see them 1 month, 2 months later, and it will round up, and this might help to talk them down. Yeah.
So no CTs.
No.
I would need a very good reason to do a CT.
I would try to get the reason from the pediatric neurologist. Just send ticket there, and everything is completely okay. I would just explain to parents that also narcosis has a risk, so maybe they give up then.
Concerning the CT, I don't know the question, but we have the newer machines where we know that the
radiation
really went down a lot. Did this change anything for us when we want a CT scan more or less? Because I think the new machine has radiation almost like X-ray of the chest. Yeah.
No, that's not. No,
Okay.
no. X-ray of the chest has 0.1 millisievert, and the CT, low dose CT has 1.7 millisievert, and a normal CT where you also can see the parenchyma has 2.5 millisievert, and in former days where you think about it was 10 millisievert, but now it's about 1.7 for your question, but the thorax has 0.1 millisievert.
But did this influence us in asking for maybe again a little bit more CT scans or not at all?
The question is always, what are you looking for in the CT scan? You want to know the diagnosis? Because ultrasound is very good in showing you the diagnosis. And if you just want to reassure yourself,
Exclusion of a multi-suit.
ultrasound.
Yeah, but sometimes there are children. I had 3 cases with frontosphenoid craniosynostosis. When I see it for the first time, I thought it is unicoronal. It was 20 years ago. I did ultrasound, both coronals open. Then after a few months, he returned to me. There was worse shape of the head. I do the CT. Everything is okay because no one was looking for the frontosphenoid. So it's always to keep in mind that it could be something small, but as Bonito said, if there is a craniosynostosis, it will be worse. Mm-hmm. So nowadays, probably with the photogrammetry, we can check that something is not okay, and then go to the refer to the imaging.
Yeah, regarding the specific point of frontosphenoidal in unicoronals, I think there'll be soon reliable morphological parameters to make the difference without the need of CT scan. There is the Uppsala team who is working on it quite precisely. And we are not used to analyze the phenotype so precisely, but we will have tools to make the difference between the unicoronals plus minus frontosphenoidal synostosis with morphometric measurements. I think we can avoid CT scan for this as well.
Yeah, I think what you're saying is right, but if you see that it's getting worse, then of course I would get a CT or an MRI, better a CT. Then you didn't, of course. But the question is, because CT is now less radiation, should we give every child a CT? I think I would say no. Of course, we're a little bit more less reluctant, but just routinely CT everybody. Yeah, I mean, if you have a clinical question, then of course we all do CTs. The question is, how often do you want to do it? And routinely, I wouldn't suggest it.
But Sarah's question goes into reducing radiation dose, and I don't recall how we reduced the protocol, but in the cases, former times when we did these frontal advancements, we were also discussing ourselves, do we need a pre-op CT for planning reasons? And there we have a special protocol with a reduced radiation, but then it's not about diagnosis, it's more about doing a pre-surgical planning and reducing intra-op time and having a better prediction of the surgery.
Yeah. And also there we were discussing to switch to black bone MRI, but yeah. Okay, but controversial as you see, but very interesting. So thank you. Just to draw your attention to this, so when they looked at who orders CTs and MRIs, so the craniofacial and the neurosurgeons did it less than the pediatricians, especially the ones the pediatricians ordered usually didn't lead to operation, and craniofacial surgeons and neurosurgeons did lead to operation. And you see, there are still people who do CTs, and the study showed the difference. So for the pediatric colleagues that are here, we always say in Basel, please just send us the patient, because usually we can assess it clinically, and there's no need to do X-rays or CTs before they are seen in our center. Just keep that in mind. Okay, next question. It should pop up in your Slido. All craniosynostosis patients should undergo genetic testing. I know it maybe it depends, also needs to be here, but try to go with agree, disagree. I know what to ask, huh? She's not here, the genetics woman. No. Too bad. Okay. What do you say? Putting you on the spot, I'm sorry.
I put disagree, but somehow I also agree, because I think not undergo testing, but what Isabel Filges mentioned in the morning, I think we should at least offer a consultation by a geneticist to discuss what implication this could have, and to also see the patient and discuss this with the parents. Yeah.
Well, I would say I'm not a geneticist, so I would say practically speaking, maybe not, but conceptually, yes, because we won't learn anything new if we don't scan the genome of this condition, because as Roman said, our wet dream for the future is to be able to treat this medically. So the clue is probably in the genetic information. So so as far as we have money for it, well, I think it's very useful and it's not invasive for the patient.
On the other hand, of course, we know that there are some other factors like valproic acid during the pregnancy, but why not to have mother with the valproic acid and genetic condition? Yeah. So I agree.
To do. Yeah. Okay.
I think I agree as well, but there are two approaches for genetic testing. There's the full genome sequencing and then the panels. I think for the panels, there is not so much doubt because there is probably a very high rate of undiagnosed Seydt-Rotzen syndromes and Moenke syndromes around in our single suture patients. And this is not very good for instance, for the cognitive management. For the full genome sequencing, it's more questionable. I don't think, at least in France, we are not ready to have systematic full genome sequencing for all patients because we don't have the infrastructure for analyzing them. But offering a panel, I think, should be systematic for all the craniosynostosis patients.
Lomi?
No, I don't do for single suture. I'm not looking for trouble. I'm not interested in finding things that will just make everybody berserk. Patients are running between 20 different experts after somebody found some piece on a chromosome that has 3 patients around the world. So they're sending consultations all over. So in the sagittal synostosis, when we looked at the neurology, there was only 1 patient which found eventually a genetic abnormality. Now, we haven't done on them, but they're not sick. They're well, they're doing well. So I don't see any reason for 1 in 200 or 300. I don't see any reason to screen everybody. I think money is an issue. I think resources is an issue, but more an issue is finding, it's like an incidentaloma, in finding things that have no significance. I've not seen a single suture synostosis that eventually was found to have one of the syndromatic diseases. So in our situation and our setup, I just don't see a reason to do it.
Can I ask you, do you do it routinely?
Yeah,
in your
I
patients?
think there is we don't have the figures yet, but there is a significant number of scaphocephaly patients, for instance, who have SMAT6 mutation with higher risks of autism. So I think it's something we have to talk with the parents early because the risk of cognitive impairment is much higher when they have this mutation. So it's something you have to prepare with all the social support to help those families on the long term. So I think it's worth it for. I mean, the panels have a reasonable amount of a reasonable number of genes that are known to be significantly mutated in those patients. So I think it makes sense, and it's not that expensive to make panels. Maybe it's my French side that healthcare is free in our country, but it's to me it's very reasonable to propose it.
I don't think you have a way to prepare that your child will have an autism. What is there to prepare? You will see if your child is autistic. There is no reason to prepare for that. And also, in our 500 cases, there was 1 autism. So that thing about many autism in sagittal synostosis, at least in that part of the Middle East, doesn't work. And autism, it's another thing that has no treatment. And if the child will have a problem, they will go to a neurologist and be diagnosed. And autism is not a genetic diagnosis. Some of the autistic children have genetic abnormalities. So altogether, I stand with my refusal to do this on a routine basis. To do things just to know, it's just not, it's not a good argument.
I mean, I cannot agree with this approach of autism. There are some preventive treatments that help the children to have a much better outcome than if they are not followed up early. And the number of autistic patients in the single suture craniosynostosis population is now known to be significant. So I think this is one of the areas where we have made some progress for the last 10 years.
Any comments from the floor? Benny.
I have when I have the impression that the child has a syndrome, I strongly recommend the genetic consultation, of course. I have a lot of patients from a more rural area, and the parents, they ask a lot of questions about the reason of the disease, but they normally don't like genetic examination. How is it in Basel?
I mean, we also have these patients, I mean, coming from Appenzell, maybe not only with a craniosynostosis, but also with cleft with Andreas, and it's the same discussion. So you need a lot of time to explain them that you have the possibility to test or to do some exams, but at the end they will decide by themselves. But I personally like to overhand this talk to the geneticist so they can have a consultation, and speaking with the geneticist, they can answer better the question about autism and whether this testing has any implications. So I try to overhand this to the geneticist. Yeah.
Okay, you know, if you present us the data, we will be excited, and maybe in 5 years we will have the same question, and maybe it will be 100% to 0 or 0 to 100%. I don't know, but it's an interesting debate. I find it fascinating. Good. Let's leave this out. I wanted to show you this case. Okay, we have 10 minutes. Just discuss what we discussed before. This is a CT of a 2-month-old child. He was diagnosed with a syndrome, and you see this head shape. And you know, for the sake of discussion, again, he has multiple synostosis. He has a turicephaly. He's doing fine. He has a little bit of headaches, and he had papillary edema. But he's, you know, a vivid child, doing very well, apart from the mild papillary edema that he has. And the question would be here, what would be your suggestion? Would you do first a FOA? Would you do a posterior vault distraction? Would you combine? Would you go also for the posterior fossa? I know it's not a lot of images, but maybe you can give me an opinion on what would be your take at it, and at what age would you start treating? No, this is just a case discussion, sorry. Oh, you're disappointed. Sorry.
I can tell you what we'll do in our department. He seems very turicephalic and brachycephalic, so we'll start with posterior distraction around 4-6 months of age, and then FOA around 8-10 months of age.
Okay, and when you do the posterior distraction, I mean, he's like flat from top to bottom. So how far up do you go and how far down do you go?
We would do some kind of superior hinge with a low section and springs, so that there would be a posterior tilt of the lower part. Okay, so you do the craniotomy, you cross the transverse sinus, all the way down. Yeah, you go all the way down to the foramen magnum, or all the way down? Yeah, if it's possible, all the way down, and then 2 springs, and then a posterior tilt of the posterior flap, and then with springs potentially, and then after a few months the frontoorbital advancement. But it's hard to say tell the severity of the turicephaly, but it seems quite severe. Yeah, it is. And you do that with 1 incision? Yeah, the same incision for both. So we do a very posterior. Go all the way down. We use the very posterior incision for the frontoorbital advancement. Yes. But this same incision you can afterwards also use for the. Yeah, we can always use it for the anterior. Okay, so 1 incision ear to ear, but behind the ears, I guess? Or no, we do the anterior part of the incision in front of the ears, not very low, and then quite posterior one, like the same kind of incision that we use for scaphocephaly. Yeah, okay. So a little bit more behind, but still in front of the ears, and then you go all the way down, dissect the muscles, and do the whole shebang. How do you protect the sinus? What are your tricks, maybe, for, you know?
You told that there is slight optical edema, yeah?
Slight optical edema.
Okay,
you would do another approach?
No, I will do the same, surely. Without this, probably I will wait for 4 to 6 months. Yeah, until 4 to 6 months. But if
you have a papillary edema, you will do it before.
Always, yeah.
Okay.
Just like when you operate the sagittal synostosis, you go over that. There's
easy,
no big issue. I think so.
Because the problem is when you do this, when we do the sagittal synostosis, we take the bone away. Yeah. But here, you don't take the bone away. You just do the craniotomy, right?
Just do the craniotomy.
So it's more difficult to get between the bone gaps going to the transverse
I don't
sinus?
think so.
No. Okay.
If there is Chiari malformation, I will open the foramen magnum. But if not, we'll go down, but not
all the way down.
Not all the way.
Okay.
Yeah, I mean, I don't have any better suggestion, but I would definitely like to have more workup to see to MRI and venography and all the stuff. Yeah. So, but I mean, principally, it's nothing to argue about.
So the ventricles are like this. There's no Chiari malformation. The posterior fossa is okay, is wide. There's no compression there, and the brain. It's abnormal, yeah. But the tonsils are not going down.
You would all use springs.
Oh.
How about free floating flap? Wouldn't work if you do it at 2 months, let's say. So if you do it early, no springs. If you do it later, you use springs.
Yeah, but if we can also put springs in 1 month, as I show you. So.
Is there advantage in putting springs?
Yes, because with the spring you will push it more.
Don't you think that at this age the brain itself will expand it?
Of course, we did it many years ago, but nowadays I will use springs.
And you see better results?
Yeah.
Okay. Shlomi, a different take on this?
No, I agree. I wouldn't put a shunt. I agree it's too early to do a frontal advancement. So I agree that if the eye examination pushes you to do something rather than gaining time, I would go to the back. Personally, I would just open bone. I think we can leave a lot of bone open, and the rest we can hinge or put absorbable plates, and the brain will push the back to be expanded backwards, and you can easily gain 2, 3, 4 months by doing so.
Okay.
The only concern is that there is a specific issue. There are specific issues with bone formation in Seth-Rotten syndrome. So the bone formation is generally specifically poor in this syndrome. So generally they have residual gaps when we do too much of openings, specifically for Seth-Rotten. It wouldn't be the same for Cruzon.
So that is something that maybe we shouldn't put in springs. I mean, because it makes the gap wider, no?
But it's somehow a distraction spring, so it's all right. It's when you do big, large craniotomies that you have, or in the coronal regions of large frontorbital advancements, there are always big bone gaps in Seth-Rotten syndrome.
Yeah. Maybe a technical question? How do you do the craniotomy? With the craniotome, with piezo? Piezo? Craniotome? Maxillofacial? Neurosurgeon? Okay.
That's because we are contrary to Shlomi's belief, we don't use springs. We do also absorbable plates in these cases. But is there any particular risk of epidural hematoma in these surgeries?
I don't.
You don't know?
In Seth-Rotten.
I mean, if you use springs, I mean.
Not to my knowledge.
We didn't have more than 100 cases.
When I was in London, there were 2 cases.
Yeah, that would.
It resolved to the time, and one had surgery afterwards, but there is.
Yeah, but as far I know from Jelani, Professor Jelani, and from the paper, they detach the bone from the sinuses. So in the surgery that we can do is just open like for the structures. Just do the craniotomy and put the springs. It's enough. I would never do before like Professor Constantini is telling. We can just remove it. But nowadays we have tools for that. So it's always less just to cut the bone and put something that will slightly distract. Even with the commercial springs, we have forces 1.0 or 1.6, so we can adjust that. Yeah.
Maybe this is an important technical point, because we are used to, when we do craniotomies to release the dura. In these cases, we try to not release the dura.
There is no need for that.
There's no need. Yeah. Okay. Two more minutes for this. So now I got you an MRI. So this kid had had a front orbital advancement first, and then he came to us with papillary edema, and we did the occipital distraction. And let's say now for the case, it didn't happen, but I'm now saying hypothetically in 6 months the kid has papillary edema again, and you see I think the FOA is okay, the posterior distraction is not bad. If there's papillary edema and you see these ventricles, would you do a revision surgery with the distraction in front or in the back, or would you now go for a shunt?
It's really a neurosurgical question. I think our neurosurgeons would do a posterior distraction.
Would repeat the posterior distraction first.
It's not my expertise.
Okay.
Or check the intracranial pressure.
You would do an ICP. He has papillary edema.
Yeah, you're right.
You would still, or you would do an ICP, and if the ICP is high,
If there is high programmable valve,
okay.
or probably put the shunt and then posterior distraction once again.
And why not only posterior distraction?
Because it doesn't work from one day. Yeah, so.
You mean
Not to-
because he has high
not
ICP,
to destroy the brain,
we need to
yeah.
treat the ICP. How about putting an EVD and doing a posterior distraction?
Mhm.
That could be an idea.
Yeah.
What would you do, Adek?
I didn't understand. EVD or ETV?
EVD, like external ventricular drainage for, to deal with the and do the posterior distraction, and then after a couple of days, probably you can remove the EVD. Just an idea.
You believe that expansion will resolve hydrocephalus?
I'm the one asking questions.
I ask back.
You didn't understand the concept.
But,
I'm kidding.
I don't know how profound is the papillary edema. It's only 3 months after surgery, right? Or 6 or
6 months after
6 months
surgery.
surgery. Well, maybe try to wait a bit, and then the shunt would be probably the first idea.
Okay. Shlomi is nodding. What would you do, Shlomi?
No, I'm just saying, I'm trying to teach my residents to always say there are several options here. But I would also put a shunt.
Sarah, you said us something about biparietal.
Every time that's the case with you, I say, what you do with biparietal decompression? You always say, no, try something else.
But
At least an option.
He seems brachycephalic.
yeah. I'm not. I don't know. Does anybody have experience with biparietal decompression, distraction?
Just from the sagittal
Let me give you the
image.
microphone.
It's just an impression from the sagittal image, but I think the posterior aspect of the brain looks more normal than the anterior aspect. So maybe an anterior advancement could also, again.
What do you say about that? No, so I would say maybe Irina can comment, but I would say this looks less compressed than this. But the question is if the FOA will solve the hydrocephalus, and I think usually it's the posterior vault expansion which solves the hydrocephalus, then it's the FOA.
May I ask a question as a non-neurosurgeon? Would it help to do a ventriculostomy? Because you don't have a crowded intratentorial space. I see some pre-pontine CSF flow.
So
Or did you already do that?
we don't see a blockage anywhere.
Yeah.
So it's probably a communicating hydrocephalus.
Okay.
It's a discussion if ETV might help in communicating hydrocephalus, but we're not there yet to say that probably it won't work. And also he's still a child. I think an ETV here is not a good option. What do you think?
And how much did you expand before, and how low did you go?
We expanded 3 centimeters.
3 centimeters, okay.
Over a period of time. Wie viel ist es gewesen, Benito? Das ist der Mallory.
Yeah, but going down, below the turcula. Not really.
No, we didn't go below the turcula. Do you think that would be something that could help?
Yes. There
Okay.
is still Pascal law in physics that, you know, the pressure is the same in the whole water. Yeah.
Okay.
Well, maybe I've missed something, but we're speaking about hydrocephalus, not. I mean, if the problem was only in hypertension with papilledema and no ventricles to see, then I understand the discussion. But when you have hydrocephalus, I'm neurosurgeon. I'm sorry, I was thinking the brain, not the calvarium display in this particular case. So I think much more sense in putting in a shunt if something. So. Because otherwise, if I agree with your thoughts, so we're speaking about the hydrocephalus ex vacuo, but is it the case? I don't believe so.
No, so we put a shunt, but but it's an interesting discussion because I don't know if we know the truth, and I think maybe each patient also reacts differently, but I think it's important. Also for us neurosurgeons, you know, if I'm looking at myself, we see a hydrocephalus, we think shunt. But in these patients, maybe it's not, maybe it's right, maybe it's not right. But you need to know that there are options, like Shlomi says, and you need to discuss with the family, and you need to take your experience and whatever, and know that you have different options. Did you want to say something, Benito? Any questions?
As another point, do you use sometimes like diamox in such a case to maybe bridge or to see how maybe the papilledema will decrease and then it stabilizes itself?
I think it's a fair option, right? It depends. I think in Shlomi's series, there was also one patient who received acetazoline.
Diamox, yeah.
So it's a pretty good chance that it can help in temporarily at least. So yes, why not?
For how long?
It's another question.
I think it's one other option. You need to keep in mind that Diamox, you know, maybe it will work, maybe it will go away, but maybe the hydrocephalus will come back. And Diamox also can cause some side effects, of course. But if you give Diamox, you need to control, you need to keep on looking at the patient. But I think it's a fair option, right?
Yep.
Would you do a lumbar puncture since the infratemporal space is quite wide to measure the pressure and to just drain some CSF and decrease the pressure?
I have to admit, but the idea crossed my mind. But in principle, I don't believe in lumbar pressure so much. But you know, in a rescue situation, yes. But
you don't believe in the pressure you measure
no,
in
I
the
don't
lumbar
believe
puncture.
like the lumbar opening pressure.
Yeah.
Generally.
Ooh, that's a big discussion you open now, but we don't have time. If you don't believe in opening pressure, maybe it wouldn't work.
It's obviously not a high pressure situation, right?
Yeah.
So it's not a constriction problem either, I believe. You know, so.
And the lumbar puncture itself, you would do it as diagnostics, not as a treatment. Okay, I'm not sure that would treat the problem. Maybe, you know, for a week, 2, maybe 3, but I don't have any proof of that, of course. Okay. Excellent. Thank you very much for your opinions. And I will give over to Raphael. Shlomi, thank you very much for your participation.
Thank you.
Fantastic. So I will make it pretty short, closing remarks. I I think this was a great day. Lots of great talks. So I really thank the speakers who traveled from many places to bring their knowledge and make it for a good discussion. Good discussion in the end also. I think we always liked for the past several years these round tables because it's kind of an open forum where we can have opinions. So thanks to all the participants who came today. Without participants, no symposium. So that's great that you came. And we will have apéro riche. So don't disappear. There should be drink and food with alcohol because that's it. Whoever wants to stay or has plans to stay, we will have the social network dinner at 8 in the restaurant Atlantis. You should have all the information. There is a disclaimer in the program that you can forget. You don't need to pay anything unless you go overboard with strong alcohol. But otherwise, it's actually paid. I think this is a compliance sentence for the sponsors. So with that, again, thank you all for being here, for discussing, for giving lectures, and for enjoying the apéro with us now. Thanks much.